Hi, happy Monday, everyone. I hope everybody's having a great start to their week. And tonight we are going to just change things up a little bit by talking to a gynecologist that is in our local area. She's actually in Miami, that works with some of our patients. And I wanted to bring her on because we've always had lots of questions about pregnancy and COVID and all kinds of different things. And also, I want to really bring out some of the discussion about inflammation, what to do to actually have a healthy pregnancy. So we're going to go ahead and bring Dr. Echeverri on, and just a quick second. So we'll be taking your questions tonight, and we'll also be talking a little. Oh, there she is. Hello, how are you? Let me turn up my speaker. Can you hear me okay?
I can hear you.
Perfect. All right. Thank you very much for joining us. Let me just flip this here. So for those of you who don't know you, I'd like for you to introduce yourself if you can a little bit. So,
Of course. Dr. Echeverri. I'm an OB-GYN practicing here in South Florida. I did my residency training at Jackson Memorial Hospital, which is the highest risk center down here. And now I've been practicing in private practice for the last 2 years here in South Miami. On my free time, I also volunteer a lot with the homeless community, especially during the times of COVID.
Awesome. Thank you so much for being here. Several of our patients have mentioned you. They really, love what you do. So I wanted to introduce, our practice, also myself, and to say hi. And also, I know that you do treat a lot of women who are wondering what IVF, since you guys are in the same building, I think, very close. So those can bring, that type of patients can bring different challenges, and then we have more challenges on top of that with the pandemic. So, and my name is Farah Duro. For those of you who I don't know, I'm a reproductive acupuncturist, and I'm in Hialeah Gardens, and I work with patients from all the way through natural conception, through pregnancy and postpartum and beyond. So it's been about 15 years of working with reproductive acupuncture, Chinese herbs, and nutrition. So we're here to every week try to provide some education also, because there's always a lot of questions around things right now that are happening. Things change all the time. So we try to give a little bit of an update and present research and actual findings, actually treatments that work, that can also help our patients. So tonight we'd like to talk about a few things that have come up with our patients and the questions that they had. And also, if you guys have any questions at all, please feel free to type them in the chat. We'll definitely be answering them. And it sounds like you have some patients already here. They're saying hi to you.
I miss you guys too. I'm currently on maternity leave. I had a baby 2 weeks ago, but I'm speaking to patients, of course.
Oh, wow. Congrats. I had no idea. Well, thank you so much, even more for this, because I know it is so hard to do a million things at once. But congratulations with that.
Thank you.
When you get back, everyone will be happy and waiting for you.
Yes.
Awesome. So, okay. So we have a few questions regarding the vaccine on every single fertility live that we do, with a lot of times that will come up: when to get the vaccine, should I get the vaccine when I'm pregnant, and that sort of thing. So if you can kind of just elaborate into, what your thoughts are on that.
Actually, I was a perfect example because I was pregnant during the times of COVID, and I did opt to get the vaccine eventually. Now, why I say eventually is because I did wait until my second, almost third trimester. When the vaccine came out, it was in December for the healthcare workers. At that time, I was just finishing my first trimester. I was still a little bit apprehensive about it. There really wasn't enough research out there for me to feel 100% comfortable to put myself out there, especially with my unborn baby. I am an IVF pregnancy as well, so she was a very desired pregnancy. And although that there has not been research specifically on pregnant women, there has been a lot of women followed throughout the process. The CDC, what they do is that women that got vaccinated in pregnancy because they chose to in December and January, mostly healthcare workers, the CDC followed them through their app. There was an app that tracks all this stuff, and followed their pregnancy, their outcomes, their births, if you had a miscarriage, also their side effects. And what they noted was that there was no significant difference between the women that were pregnant and the women that were not pregnant in terms of side effects. And also the miscarriage rate was not higher in women that got the vaccine versus women that did not get the vaccine.
Mm-hmm.
Based on these things, and obviously science, which we know is an mRNA vaccine, I did opt to get the vaccine in March. I was about 27 weeks pregnant at that time. It did, I got some side effects, the ones that we've heard of, the chills, the nausea, I got the headache, but they were gone within 4 to 6 hours. I took Tylenol, hydrated, and I was back at work the next day. What I recommend to my patients, I use this to my patients. I prefer that you think about it and you consider getting the vaccine, because women that are pregnant who get COVID, we do know that they have more severe disease, just like women who get the flu and they're pregnant. So I do encourage them to do some research and make their decision on their own. The only time I tell them not to get it is in their first trimester. The only reason I say this, it's not because there is some evidence that says you're going to miscarry or the baby's going to get harmed in any way. The reason I tell them that is, God forbid you do miscarry in your first trimester, which unfortunately is very common, you're going to blame yourself. And I never want any of my patients to ever blame themselves. I don't want guilt being carried around. So I just tell them, you know what, let's wait until the first trimester is over, which is usually the riskier trimester. Once you hit your second trimester, I do encourage that you get it. So actually in the beginning, when we were vaccinating our high-risk population, I actually stood at one of the vaccine sites on a Sunday and I went on live Instagram. I said, anybody who wants to come get it and you are my patients, come. I will sign off the form on the spot for you. And I stood there on a Sunday, and that's what I did for my patients, because I do encourage the vaccine.
So not only were you treating patients during this pandemic, but you were also pregnant yourself.
Yes.
So definitely that, it's a new thing. It's scary for a lot of people. I think that's why, but also being sick when you're pregnant is also not fun either. And so we're just now learning women with PCOS are at higher risk, and there's inflammatory things going on. So, which, makes sense, because women with PCOS do have higher risk factors for cardiovascular issues, type 2 diabetes, and you might see in your practice gestational diabetes. So we're just adding more and more risk, I think, on that's not necessary if they're able to do something about it, I think. So that's, so as far as your patients, are they, have you noticed that they prefer a certain time of the pregnancy, or is it just any time you recommend to go ahead and get it, except for the first trimester, you're saying?
Second and third trimester, I do recommend it. And now we're seeing that babies that were born of mothers who were vaccinated are being born with antibodies.
Mm-hmm.
There's some preliminary studies showing that the breast milk is actually also carrying those antibodies. So it's definitely very encouraged.
Very cool. And so we haven't reached the point yet where children are now starting to get vaccinated, but not very young yet. So just 12 and up, I believe. So we're learning, but there is a huge trial from Israel, I think, where they followed women who were trying to conceive and also pregnant for a year, and they didn't see much difference as far as the infertility rates. So that's encouraging with the Pfizer vaccine, but I don't know if they're all similar there. And so that's part of the problem, is that pregnant women were not included in these clinical trials. So that's the only issue there. So when you talk about side effects, have you noticed any side effects with your patients?
No, not really. I've noticed that people that have had COVID in the past sometimes get a little bit more worse side effects.
Mm-hmm.
But again, I had COVID in the past. My side effects were, after the first vaccine, I got very nauseous. But again, was it pregnancy or was it the vaccine? I was in my second trimester. Nausea was still a thing in my pregnancy. After the second vaccine, I did get the full-blown chills, fever, headache, body ache. Started at 2 a.m. By 8 a.m. they were gone. I took Tylenol, I drank lots of water, and I was in my office seeing patients by 9 a.m. So it was very short-lived.
Definitely. And people, you are at a high-risk population. You're seeing patients every day, and we have patients that are nurses working in hospitals that are still not sure if they should get the vaccine. So that's another issue. I think where you have to feel that you're comfortable, and also if you're seeing patients or you're seeing people on a day-to-day basis, definitely that risk can go up. So
that's a very important point that you make. When I do talk to my patients about the vaccine, I do tell them, I'm like, what is your risk factor?
Right.
Are you a healthcare worker working in a hospital that is constantly exposed to COVID? Are you a teacher in a school that's constantly exposed to COVID? Because children do carry it as well. The most of them are asymptomatic, but they can transmit COVID. Or are you working from home, because you have a job that gives you that flexibility? And I think it's a very decision, and I think it's very important that we respect every person's decisions as well, because just because I'm comfortable with it right now doesn't mean you have to be there. And
Right.
that's also very important, that we don't shame people or pressure people into doing something they don't want to do.
And I mean, as far as speaking of any complications, have you seen anyone in the hospital when you've done deliveries with complications from COVID, or, has that affected their pregnancies at all? Or,
So I think our patients have gotten COVID in the past. We've had deliveries, of course. Complication wise, no. One of my very good friends had COVID. We delivered her at term. We inspected the placenta. The baby was fine. Everything was fine. With the vaccine, I've seen zero complications with it. I have not had any of my patients, they've called me and been like, I have a fever, what do I do? Or, I have body aches and chills, what do I do? But nothing that needed to be hospitalized or anything that needed any immediate medical attention. Now, with COVID, patients that contracted COVID through this COVID pandemic,
Mhm.
we have some people that got sick. Luckily, their babies were fine. We saw good outcomes. However, just because my patient population had good outcomes does not mean everybody did. I have very good friends who are also OB-GYNs who did tell me that they had very, very sick patients in the ICU, not
Mhm.
only here in Florida, but in other states. So we do see that the disease burden is, it's there for pregnant women.
And as far as the procedures in the hospitals now, is it still, one visitor only allowed, or are these kind of, shifting from that?
So we are shifting from that. Currently in South Miami, I just gave birth. It was only my husband and I in the room.
Mhm.
Um, However, I am seeing, because I do keep in touch with other hospitals, that other hospitals are kind of easing up on those regulations, allowing maybe two people in the room at a time. So two visitors throughout the pregnancy, mom and partner, or best friends and aunts, whoever it is. But it's very hospital dependent, the rules, and the same thing goes with the offices. The offices are very dependent on, internal rules. There's no set guideline for everybody at this point.
Okay. And since you just gave birth, did you have to wear a mask or anything, or did you have, during labor or anything like that, or any of
So
those?
yes, we do wear masks in the hospital at all times. Although I was tested for COVID, my husband was not tested for COVID because, we're assuming that if he's asymptomatic and I don't have it, we're assuming that he is as well. We do encourage mask usage. Now, with my patients, since I know that they've just been tested, when they're pushing, I don't always make them wear a mask because as a woman, I understand how uncomfortable that is.
Mhm.
I do allow them to demasks and, go through their active labor process without a mask. Now that's as long as my nursing staff is also in agreement. I would never want to make anybody uncomfortable, so we
Okay.
all be on board.
Right. Yes, definitely. I mean, and I just remember my delivery with my daughter. I had to have oxygen myself because I was exhausted. I can't imagine that time in a mask, so it would be hard. But women do it. I just had a patient deliver a couple, months ago, and she said, "Yeah, the whole time pushed in the mask and everything." And I'm like, "Wow, but it's a different scenario." And I know, like before, we're used to having family in the room and a bunch of people present, so that is changed with this. The social aspect for sure. And, also being afraid to go outside and, around a lot of people and the baby's born and that sort of thing. So, but I think little by little we're getting there. It seems like we're coming out of this hopefully very soon. So that's exciting. And as far as, any other tips you would give someone who, I guess, is kind of going through this for the first time? What would you recommend as far as like preconception care? Have you noticed that would be
So
helpful?
this was my third pregnancy, and I've been very vocal about it on Instagram, especially. My first two pregnancies, I was in my 20s, my late 20s. This pregnancy, I'm in my mid 30s.
Mm-hmm.
I was in medical school my first two pregnancies. They were very difficult on my body. I became a gestational diabetic. I've always been a very thin person. However, there's risk factors for gestational diabetes that is not, obesity or being overweight. So I do tell my patients to keep in mind that just because, you're thin does not mean you don't have to have gestational diabetes. Because I think it's a very big some women that do get diabetes in their pregnancy. They're like, how did this happen? Are you
Right.
a mistake? Are you sure? There's other risk factors, including, genetics and family history and things like that. With this pregnancy, since I was in my mid 30s, and I'm a very active person, I wanted to be as fit and healthy as possible. As I said, she was an IVF pregnancy. I only had one female embryo. I have two boys, very healthy, beautiful boys, but I really wanted my girl. So I wanted to make sure that my body was as ready to accept this pregnancy as possible. I actually changed my diet and I started working out since January 2020. So it's been about a year and a half where I've been working out consistently almost every single day of my life. I cut out for a majority of the pregnancy and pre-pregnancy red meats. I kind of switched over to Mediterranean diet because a very good friend of mine who is an IVF doctor told me to decrease all inflammation in my body. So I switched over to Mediterranean diets. Give me 1 second. I'm sorry. It's my son. Honey, I'm on work. I'm on work. Thank you. Okay. Sorry about that.
Okay.
Hi. So I switched over to Mediterranean diet. One of my other very good friends became a vegan, so at least once a week I would try to eat vegan with her. That really did help. But I think by going into the pregnancy as healthy as possible, not only with my nutrition, but with my physical form was very important. And I did notice a huge difference in this pregnancy. I was able to have more energy. I did not get gestational diabetes this time around. I also rebounded a lot quicker. I'm 2 weeks postpartum and I started going back to the gym fairly quickly. Not in the intensity that I was used to, but I did go back to the gym within a week after having my baby. I was a natural delivery vaginally, so there was no surgery that precluded that from happening. But I think that going into the pregnancy healthy and keeping active was extremely, extremely important. With that said, since I was an IVF pregnancy and I wanted to decrease inflammation before implantation, I decreased high intensity exercise as per the recommendation of one of my friends, who's an IVF doctor. Sorry, I'm on the phone. I'm busy.
Can you hurry up?
Yes, I can hurry up. Thank you. Bye. But I did decrease everything that was high intensity exercise just to decrease inflammation in my body because I was going to be implanting an embryo.
Okay.
So I think those things really, I threw everything at it. I wanted to make sure that I was ready for this pregnancy, and I do believe that it made a huge difference.
For sure. That's definitely a Mediterranean diet, something we emphasize with our patients. And acupuncture, nutritional recommendations, and a good prenatal, and trying to keep the stress as low as possible. It's so important. But definitely, gestational diabetes is something we try to, we also work with our patients. It's just, I think stress can really flare things up a lot of times. And so as far as I know that you've got a lot going on because parenthood is crazy, and this time it's been a bit of a challenge for everybody. We have my husband working from home, my kids doing virtual school. Everyone's kind of a little bit crazy here, but I think that we're all coming out of this in a different like a shift. I think into what's important, and I believe that health is the most important thing in your life. So if like you said, you can get inflammation down, get those inflammatory markers measured, which we've been trying to get patients to do, to see a nutritionist, to work on those things. If you have the luxury of doing that before you get pregnant, I think it's just so much better as far as in the end. So when you talk about exercise, how much do you recommend to your patients? Because that's another question that we get. Like once they are trying to conceive, they try to, if they're doing IVF, they're told, please don't exercise so much or don't do so much cardio. You need to reduce that. When you're pregnant, did you find that you kind of ramped it back up, or when did you actually start back?
So I decreased, like I said, I used to do Peloton, or I do Peloton anywhere between 3 to 4 times a week. And I also weight train approximately 3 to 4 times a week as well, depending on my Peloton schedule. When I did my IVF process approximately 2 weeks before, I stopped weight training. And instead of doing high intensity exercise, I just kind of kept my heart rate up, but nothing high intensity. So most of the time I would flip a TV show on or a movie and just move my legs for 30, 40 minutes. That's it.
Yeah.
Keep going. Once the pregnancy was implanted, meaning that we knew that it was a successful IVF transfer, there was gestational sac and an embryo in the uterus, I started to slowly increase my exercise and go back to doing my high intensity classes. But to be honest, I waited until I was about 12 weeks, just to make sure.
Yeah. Definitely, and be in the safe zone there. So, I think it's helpful that you've gone through the process of IVF, so you understand what women are going through that are doing this, and also that you work so much with women also that have been through that. As far as women who have gone through multiple miscarriages, do you have any particular recommendations? I know that every case is different, but when you see them during pregnancy, I know that there's a whole, we see a lot of emotional component about, a lot of times a little bit of PTSD goes into that. Like, is this gonna last, or is this gonna be healthy, this pregnancy? So do you have any specific recommendations for women that you see specifically that are going through that? Obviously working with perinatologists probably, but any other?
Yeah. So for multiple miscarriages, I do initiate a workup after the second to third miscarriage, depending on the women's age, as per recommendations. I think that finding an answer on why it's happening does help women a lot.
Mm-hmm.
The thing that I've seen very close friends of mine struggle with is why. Why is this happening? Either infertility, meaning they can't get pregnant, or why are they having miscarriages?
Mm-hmm.
Initiating a workup early on, I think, is important because that's going to help with the emotional factor a lot.
Yeah. Mm-hmm.
When they actually do get pregnant, and this is not only women that have miscarriages, but women that have had ectopics in the past. I have a lot of young patients that are traumatized from having an ectopic and ended up in surgery in the past.
Mm-hmm.
I'm very conscientious about that past. I'm sorry, Papi, please stop. Sorry.
That's okay.
So usually we just do fetal Dopplers in office every 4 weeks. For these patients, if they ask me, can we see the baby on ultrasound? Absolutely, 100%. I get it. Even my IVF, we need that reassurance. We need that visualization of the pregnancy in order to calm our anxiety and our fears. So I think that's very important, is to communicate with your doctor. Tell them why you're asking for these things. Can I have an ultrasound instead of just listening to baby's heartbeat? Because I've gone through 2 to 3 miscarriages and it was so terrible, and I'm so afraid of losing this one. Absolutely. And all of our OB-GYNs are on call 24/7. So for some reason you're having something going on a weekend that you're not sure, please call us and let us know. We'll talk you through it. If it means going to the emergency room, I tell my patients all the time, that's what the emergency room there is for. You have insurance for a reason. Do not be afraid to use it. I've had patients that, are like, oh, but is it necessary? Recently, and we sent her to the emergency room in her early 3rd trimester, and thank God that she went, because she ended up in a stat C-section and we had to deliver the baby in 29 weeks. Whatever what she was feeling that was off, it was a correct feeling. She, as a mother, knew something was not right, and we were able to save that baby's life, because of that one phone call that she did on a Saturday night at 8 p.m. to tell us, I feel off. I'm not sure what it is. Something's off. Go. Use the resources that we have. So I think that's very, very important for all our patients to realize. If you have some spotting, please come in. Let us figure out why you're spotting. Don't just dismiss it as, I just had intercourse or whatever. So I think that's very important to ease the minds.
Definitely. And you guys are located mainly in South Miami, correct? Like at the hospital, or that's
Yeah.
mainly?
So my office is a block away from the hospital, and I work out of South Miami Hospital.
Okay, yes. Right. And I think people are scared still to go, to the hospital, unfortunately. And, I don't know how South Miami handles it, but other hospitals, they have different sections, obviously, for COVID patients than for pregnant women who go through it that way. So would you see the risk is pretty low as far as someone catching COVID in the hospital or that sort of thing? Because a lot of women I know are trying to get pregnant, they still have not been vaccinated, so they are a little concerned, about where they're going. Yes. So,
but yeah, we separate in the hospital, in the emergency room downstairs. We separate COVID patients from non-COVID patients, and then upstairs, for our pregnant patients that have viable pregnancies, meaning after 24 weeks, there's a complete different emergency area for those patients. They do not go to the regular emergency room. There is an OB triage area for them.
And as far as the role of doulas, are doulas allowed in the hospitals now? Do you know, or because for a while they were not?
For some time right now, they have not. I have not heard of an exception being made unless they are the. Some women have opted to have their doulas as their birth. Instead of having a husband or a mom or whoever it is, they want somebody that's actually going to coach them through the birth and help them through that. Right,
definitely. Hopefully that will change soon because they're so helpful. Doulas are awesome. So, I think, as far as the questions, you guys are welcome to type them in the chat. Trying to look and see if we have any that have popped up here, but I don't know if anything is, because we're covering so much stuff already. Okay, so last couple questions I had is basically Okay, is a mask required during labor if a patient has been vaccinated? Oh, that's a good question, right? I mean, do you guys make a distinction or that's?
So it's provider dependent, to be completely honest with you. You're gonna have to talk to whoever your OB-GYN is. Again, I believe in science. I believe in the vaccine. I'm vaccinated. All my nursing staff is vaccinated. When I was my labor room, it was my physician, who's one of my partners. She's amazing. She was vaccinated. Both of my nurses were vaccinated. My husband was vaccinated, and I was vaccinated. The usage of masks at that point was no, to be
Right.
honest with you, because the entire room was vaccinated. But again, it's provider dependent because we do have to respect our providers as well. If your provider, you don't know your provider's health issues. You don't know if I'm going through, God forbid, a cancer or chemotherapy, or I have an
Right.
immunodeficiency
Mhm.
that puts me at higher risk. So we do have to respect even our providers' wishes. If they're asking you to wear a mask, there has to be a reason behind it.
Definitely. Yeah. And we just have a question popped up here. Can I have a healthy pregnancy if I have MTHFR?
Yes, you can have a healthy pregnancy. We will be watching you a little bit closer, and we'll be sending you to the high-risk doctor, which is the perinatologist, to help us co-manage your pregnancy. Just because we use a perinatologist, not a perinatologist, maternal fetal medicine specialist, does not mean that we're abandoning you. They just help us co-manage your pregnancy. We will still be delivering you, but they will be giving us recommendations to make sure you have the healthiest pregnancy possible.
Definitely. And we think that most prenatals now have the methylated folate in them. I mean, a lot of the prescription ones definitely, and the good, formulated ones. But a lot of people bring in prenatals that don't have that type of folate. So, and we can assume we don't know. Not everybody's been tested for that for the
Yeah.
intent patients. So, we always say just check your prenatal, make sure that you have a good formulation there. Hi there, you're adorable.
Graduated today from kindergarten, and he lost
Oh, congrats.
his
Oh, you
mouth.
love tooth. I can see it. Nice. Okay, what is the name of the specialist that they're asking about? Mhm.
It's a maternal fetal medicine specialist, an MFM.
Okay, very good. We have another question here. Oh, goodness, there they are. Okay, I have them here. All right, so we're gonna pop it up. So funny, I didn't see it. Okay, protein S deficiency diagnosis overwhelming while trying to conceive. How is it managed a viable pregnancy?
So again, the MFM specialist is the one that will guide us in that. I don't want to give specific recommendations because I really do need to look at the entire picture, not just the diagnosis. Are there any other risk factors, your age, what point in the pregnancy you're at, things like that? Do you have a history of miscarriages before I can make any recommendation? But I usually do, I work with a maternal fetal medicine. We work with multiple. They are covered by your insurance. We go with the recommendations. They're the ones that are going to be doing your ultrasounds, who are going to be helping us co-manage you, and again, we will be delivering you.
Awesome, thank you. And the questions are coming in now. I was previously pregnant and had preeclampsia. Could that have something to do with it? Oh, wait, maybe this is a follow-up from another question here. Previously pregnant and had preeclampsia. So sorry, I'm trying to see if there's a question before that.
So while you see that, I'm seeing a question about PCOS and
Yeah,
changing.
okay, let's do that.
Number one thing I actually do recommend my patients with PCOS is losing 5% of the body weight. Losing weight, even as little as 5%, has shown to help PCOS patients begin to resume ovulation and get pregnant naturally. So that's actually number one recommendation right off the bat. We're trying to get you to resume ovulation monthly, which is the problem that we have with our PCOS patients, is that most of them are not ovulating, which is the reason why they're not getting pregnant. When we lose weight, we kind of resume that.
Okay, very good. Yes, and okay, we have a question here. We're going to go to that and we'll get back to the other one. Okay, are you allowed to ride your stationary bike in the first trimester?
Yes, please ride your stationary bike. Don't ride your non-stationary bike because you risk falling
Mhm.
anytime. But your stationary bike, again, is 100% safe. You can ride it. I usually tell my patients, whatever you're used to exercising before the pregnancy, you can continue doing through the pregnancy with limiting weight. Intensity-wise, if you're able to say a complete sentence, then you're okay.
Okay, that's a good rule of thumb. Yes, yeah. I definitely no ice skating or rollerblading. Okay, let's see. We have another one here. Okay, is it more a risk if you've had gastric sleeve less than a year ago and you're already 3 months pregnant?
Is it more, what was the question, more or less of risk?
Is it more risk if you've had a gastric sleeve less than a year ago and you're already 3 months pregnant?
So the reason that we usually tell you to wait a little bit is because of vitamin deficiency. After any kind of gastric surgery, you can have a vitamin deficiency. So we want to kind of monitor that. So you should have your physician monitoring your vitamin levels as well.
Vitamin D too is so important in pregnancy. That's a lot of depletion sometimes with that surgery. Okay, and here's another, let's see, another question here. Let me just go to, do MTHFR patients always have to be on Lovenox or any other anticoagulants during the whole pregnancy?
Again, it depends on how you were diagnosed, what your diagnosis is. We really do need to see your labs and your history and your records in order to make better recommendations.
Yeah, sure. And let's see here. Okay, we have a question on how long should you wait to try to conceive after a miscarriage?
That's a great question. So it depends. How did you have your when you miscarried, was it naturally? Did you naturally miscarry, meaning that you didn't need the assistance of medications to pass that pregnancy, or a DNC? I usually tell my patients, anywhere between 1 to 3 months is okay, especially because I have a population that is just not ready. They kind of need to process that, and they want to wait longer, which is 100% okay. And then I have another set of population that are really anxious to get pregnant, and they just want to make sure they can get pregnant. The main thing is that we don't want to confuse your new lab results, so your beta, which is your hormone level, with the old pregnancy versus the new pregnancy. So we want to make sure that your old hormone level is completely zero.
Yes.
Because we have that lab value, or we did a DNC, or we're 100% sure that the pregnancy was passed.
For sure. Definitely, when you're emotionally ready too. I mean, it sometimes is a big factor in that as well. Okay, so let's go to our next question. Thank you guys for bringing these awesome questions in. I've had PCOS since I was 18, and I was 100 pounds lighter than I am now. I had issues getting pregnant then as well. I'm now 37. Okay, I have issues getting pregnant now. I mean, definitely you work with a lot of, and we both work with great reproductive endocrinologists. But, as far as someone who has PCOS and is 100 pounds overweight, we definitely would recommend a nutritionist, for that. Would you put them on anything or just recommend nutritional consultations first?
So I would definitely, nutrition is huge. I usually would recommend, especially at 37 years old with trouble getting pregnant, I would jump really quickly to seeing a reproductive endocrinologist for them to guide them. I know that most of the IVF doctors in our area do start them on metformin. Their studies have been controversial in the past, but it doesn't hurt. So anything that would help, I believe, does help. The nutrition part of it, exercise, and then trying to see if the patient's actually ovulating, which we can do by doing labs.
Mm-hmm. Definitely, and we work so much from a natural perspective with PCOS that we find, and we've had patients who lost 100 pounds and they are able to get pregnant naturally. So, that 60 to 100 pounds, sometimes you don't even need to lose that much for your ovulation to start kicking in. So definitely don't feel that just, someone telling you just lose weight and everything will be fine is enough, because it's usually not enough. You need support. You need a good team, and along with a nutritionist, usually if it's that much weight. Acupuncture can help, exercise can help, getting your stress level down, all those inflammatory markers we talked about before can help. So definitely don't give up. I know it is a lifelong battle. I have PCOS myself, so I can tell you it's not easy, but just knowing that what to do, and that's what we try to teach our patients, like what to do to actually help regulate the cycles and feel better and keep the blood sugar balance for the rest of your life is actually going to help. You're not going to menstruate for the rest of your life, but you are going to want to be fit and have your cholesterol level good and your thyroid in check and all those things. So it's really maintenance. It takes a little bit more maintenance, but once you get it down, it actually is extremely helpful to know these things. So pregnancy is a side effect, right, of getting that in check. So.
When we recommend that you see a reproductive endocrinologist, does not mean that we're jumping to IVF. I don't want my patients to think that. There are other methods that we can do. Ovulation induction. We can give you medication to make your body ovulate, and then you can have timed intercourse, which can increase chances of getting pregnant. There's also IUI, which is intrauterine insemination, basically getting your partner's sperm and then inseminating it in your uterus when you are ovulating, either because we're just watching you ovulate naturally or we're inducing ovulation again. So there's different things that we can help you with. It's not always just jumping straight to IVF.
Very good. Yes. Okay, we have another question. I'm having trouble gaining weight. 22 weeks and babies in the 13th percentile.
So again, then in your case, I would also probably resort to talking to my maternal fetal medicine specialist to make sure that there isn't something else going on, especially if the baby's in the 13th percentile. With you, I would, recommend 5 small meals a day, maybe bring you in a little closer together than every 4 weeks, maybe see you every 2 weeks to make sure that we are gaining weight appropriately, making sure that it's not nausea or emesis, which is, vomiting every day, that's precluding you from gaining weight. But on the other side, I would want the maternal fetal specialist to be making sure that your baby's okay and growing appropriately. If your baby's a 13th percentile throughout your pregnancy, maybe you just have a small baby. Are you a small person? Are you constitutionally small? That's okay as well. Mm-hmm. Now, if that's not the case and there might be something wrong, we do need to see somebody else. Is there hypertension? Is there diabetes involved? Is there other medical conditions that can be causing this?
Right, definitely. Mediterranean is also good. Mediterranean diet for sure during pregnancy is excellent if they can incorporate some of those. So they're saying, what can I do to gain weight? I'm eating normally, but nothing seems to be working. And that's a problem, for, I'm trying to get that question up there, but it wasn't popping up here. But again, it's the same, I think also the nutritionist comes into play. They have a great nutritionist also. The clinic we work with, IVFMD, has, an excellent nutritionist. So for preconception care and also I would think during pregnancy, it'd be very helpful to do that. To reach out. There's help available. Do you have any other references in that department, or what do you usually recommend to your patients?
Watch them a little closer. There is a certain amount of weight that I want to see you gain. Mm-hmm. Just not gaining 20 to 30 pounds does not mean they're just concerning. It depends on the person. If the baby's growing, if the baby's maintaining 13th percentile, I am okay with that. If you've gained 5 pounds in the first, 20 weeks, I'm okay with that. It all depends on the person. You have a global picture. Not just I'm not gaining weight, or I think I'm eating too little, or this is less than my other pregnancies. Mm-hmm. What going on, and when you look at the person.
Okay, very good. Another question: does having an HPV affect getting pregnant?
It does not. HPV, it does not have anything to do with getting pregnant. HPV is the human papilloma virus. It's what we test for when we do your pap smears. If you have HPV, especially starting classes, and COVID-19 is a perfect example of this, because when I say HPV and what strain it is, people used to look at me like I had two heads, like what was I talking about? COVID is coronavirus, and it's strain 19, okay? HPV, which is also a virus, has many different strains. There's certain, specifically 16 and 18, that are more carcinogenic, which means put you at an increased risk of developing cervical cancer in the future, which is the reason why we do pap smears. This will not affect you from getting pregnant in any way whatsoever.
Great. This was a follow-up, I think, to the someone who posted earlier about the gyno I was seeing is older and didn't know what letrozole was, so he didn't want to prescribe it to me. I did lose 20 pounds recently. Dr. Joe, it's one of my patients. Okay. Hi, Denise. Awesome. So, okay. So basically, that question came in a little later, which we answered here. It's awesome that you lost 20 pounds too. I mean, I think, just keep the ball rolling with it, and whatever you're doing is working, which is excellent. But sometimes with fertility treatment, you have to have a team, so, you have a good gynecologist and also a reproductive endocrinologist you're working with, a nutritionist. Sometimes it takes a village. So that's, if the person you're working with is not giving you letrozole or fertility medication, and you're not ovulating at all, then probably you need to go beyond that, right, and get seen and evaluated too.
So for the people that don't know what letrozole is a medication that started using in the past decade or so. It's shown that women with PCOS that we give letrozole to, it helps them ovulate. Mm-hmm. The other medication that's used very often is Clomid. It's also an ovulation-inducing medication.
Okay. Great. And do you have a rule of thumb for when you can start seeing changes with your hormone cycles and making lifestyle changes? Good question.
Let me read it again. Do you have a rhythm? So yes, for the PCOS patients, again, 5% loss in body weight, we can start seeing changes in the hormones. Especially my very overweight patients that really don't have normal menstrual cycles, anywhere between 5 to 10% actually regulates your menstrual cycle. So you can start seeing physical changes yourselves just with your menstrual cycle if you start menstruating monthly. That's a plus. We do want to see that because the most difficult thing is for us to get you back on that perfect cycle. So I think that would be the main one.
Definitely. I mean, and also women who have fibroids, we recommend changing up the diet as well. And I don't know if you've seen that in your practice where the fibroids can, I think, we've seen it over and over where they can actually shrink. So they go back and they're like, oh, they're not as big anymore, when they just went vegan or they change their diet up because they're not getting as many of those hormones in the meats that they're eating and
Exactly.
that sort of thing. So, and we see it as patients who just want to stop bleeding because they have like long cycles or a lot of pain and that sort of thing. And surgery is not always the answer that they want to do, especially if they're trying to get pregnant. So have you, I know we're talking all about, pregnancy, but have you seen any differences when your patients have implemented those lifestyle changes who've had fibroids and that sort of issue?
Not personally in my practice, but I have read about it. And it does make sense. Like if you think
Mhm.
about the science behind it, if our foods are high in hormone, especially
Mhm.
for example, and we are consuming that, we are increasing our hormone levels. When we have high hormones in our body, fibroids can either grow or bleeding cycles can be irregular. If we decrease that, we technically can see a decreased growth in fibroids and a decrease in bleeding because of that decreased growth in fibroids. But in my practice, I honestly have not seen it.
Mhm. Really, yeah, and it doesn't hurt to actually start eating a little cleaner. And not everything has to be organic, but okay. So let me see here. I'm going to make sure that I think we did get to all of our questions tonight. So I think this has been super helpful. I really want to thank you because it's our first live that we've done together, and I didn't even realize you were like 2 weeks postpartum. So thank you very much for taking that time out and helping to clarify some issues here. And whenever you're back, you please, you guys follow Dr. Echeverri on her Instagram. And then also if they need to reach out to you, do you guys provide consultations or how do they connect with you guys? So
Yes, our office, we do provide consultations. I'll be back working in August. In the meantime, my other 3 partners are in the office. I have a lot of patients that are telling me, I'm pregnant now, but you're not there. It's okay. I'll be back. I'll be back in a couple of months. I promise. It's only 2 months away now. But yes, we provide consultations. We do telemedicine, and we see patients in the office in South Miami.
oh, perfect. Okay. Well, thank you so much. We appreciate this. And for those of you who would like to join us a couple days on Wednesday, actually, we're going to be having an Instagram Live with Dr. Ellen Wood, who we're going to talk about fertility issues and all kinds of things. It's very informative. And that's at 7:30 Wednesday night. And you guys can also follow me at FL Complete Wellness. Reach out to our office anytime you need us. We are here for you. And I wish everyone a great night and have a great not weekend yet, but have a great week. So see you guys soon. And thank you again, Dr. Echeverri. I really appreciate it.
I see.
Okay. Bye. Thank you.